Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, An Individual Person Data Meta-Analysis of Preoperative MRI and Breast Cancer Recurrence by Nama Houssami et al. My name is Richard Bleitcher, and I'm an Associate Professor of Surgical Oncology, the Breast Fellowship Program Director, and Breast Cancer Service Line Leader at the Fox Chase Cancer Center in Philadelphia, Pennsylvania, in the United States. My oncologic specialty is breast cancer. There really is no imaging, laboratory, or other study in modern breast care that has become as controversial as breast MRI. This modality, now 30 years old, has had its share of supporters and detractors over the years, and this meta-analysis by Houssami and colleagues will undoubtedly be either celebrated or dismissed by readers depending on their views on the subject. But whatever your view of breast MRI, we must remember that today's cost-conscious healthcare world requires that we demonstrate improved outcomes, or at least some other substantial benefit, to justify costs. The study by Houssami et al. Is the first meta-analysis to evaluate local and distant recurrence in individuals who've had a preoperative MRI and an attempt at breast conservation, as versus those who had no MRI. The study is an effort to more definitively investigate a field of data comprised of small retrospective studies and prospective trials with short published follow-up. Using individual patient-level data to potentially reduce publication bias, the meta-analysis notes no improvement in local or distant recurrence associated with preoperative MRI. In short, the authors concluded that routine utilization of MRI preoperatively does not reduce the risk of ipsilateral local or distant recurrence and should not be used routinely in the preoperative setting with that in mind. This study could be criticized because the authors were unable to obtain data from all studies eligible. Some studies follow-up was short, and not all published studies could be used because they either didn't give recurrence data or had no patients who didn't have an MRI for comparison. These caveats tell us that we need to continue to evaluate the modality, but we also need to recognize that considerable data to date has not shown the promise in the routine preoperative setting that many have hoped for. Increasingly, we must face the fact that breast MRI, like so many other tests, has advantages for particular clinical scenarios, but not as a routine test ordered in knee-jerk fashion on all breast cancer cases preoperatively. Although this meta-analysis strengthens the current literature on MRI, several hopes for MRI in the non-high-risk setting were dashed before this publication. There has been little suggestion, even among strong MRI advocates, that the modality could improve survival. This is because breast conservation therapy has had survival equivalent to mastectomy long before breast MRI was even in use. So there is almost no possibility that MRI could improve upon lumpectomy, because that would make its survival better than that which we can achieve via mastectomy. We also have a considerable amount of data demonstrating that surgical technique is not improved by using MRI, and so now, with this study casting further doubt on its recurrence benefit, the prospects for justifying its use in that routine preoperative non-high-risk setting have nearly disappeared. Ultimately, though, when you review the Houssami meta-analysis, you may ask yourself, does the data make sense? The modality is more accurate for judging lesion size and more sensitive for detecting subclinical cancer foci, but demonstrates no improvement in our ability to perform breast conservation, and now no ability to lower the recurrence rate. If you think of it solely in that light, the data does not seem to make sense. But that assumes that MRI helps us remove a significantly greater amount of disease from the breast than we could otherwise. It assumes that the disease we're removing is all clinically significant and requires resection, and that systemic and radiotherapies add little, while MRI somehow provides a sufficiently improved depiction of the cancer to improve resection. We must remember, however, that not all disease is clinically significant, and not all breast cancer requires removal. Although counterintuitive, this is because of our multimodal paradigm of surgery, radiotherapy, and systemic agents, which combine to control disease. In the American College of Surgeons Oncology Group Z11 trial, randomizing patients with positive sentinel nodes to completion dissection or observation, 30% of the observed patients had positive non-sentinel nodes left in situ, with no increase in recurrence or drop in survival over those dissected. The breast is no different. Long before MRI, we knew that radiotherapy dropped the local recurrence rate after lumpectomy, and initially we could only speculate as to why. Then along came breast MRI, making multifocal and multicentric disease visible, and confirming what we forgot about mastectomy studies, that breast cancer has multiple foci in up to 63% of cases even when not visible on mammogram. We've treated these foci reasonably well for decades, long before we could so easily see them with MRI. But, understandably, simply knowing that cancer is present doesn't frighten us nearly as much as actually seeing it on film. But recurrence rates without MRI are now merely 2 to 4% at 5 years because of radiotherapy and systemic agents. So if you decide to question the legitimacy of the meta-analysis results, you first have to ask yourself what MRI benefit should realistically drop this already low recurrence rate even further. MRI is the most accurate modality we have, but it's not perfect. It overestimates tumor sizes in 11 to 70% of cases and underestimates them in 10 to 56%, while also causing unnecessary biopsies from a high number of false positives. The only possible way that MRI could improve local recurrence would be for it to identify true positive foci that are both occult on standard imaging and become clinically significant, despite radiation and adjuvant therapy. Remember also that we know that MRI spots foci in 8 to 40% of cases not seen on other imaging. But foci in the quadrant of the primary tumor are not as likely to be helped significantly by adding MRI because we already widely excise and frequently perform a radiotherapy boost to that area. The most likely sites of assistance provided by MRI are those outside that quadrant, where only about 2 to 15% of cases show foci on MRI, but not on other modalities. And still, while some of these foci may benefit from resection, we know very little about which are significant, and it appears that not all of them are. This further lowers the potential impact of MRI below that 2 to 15% rate. What has been equally disappointing, though, is that MRI has not been demonstrated to improve our ability to remove even the most obvious disease in the breast, the primary tumor. It doesn't help us determine who is a breast conservation candidate or achieve negative margins. And even when we enlist the radiologist's physical assistance in resecting the primary by using needle localization, with or without bracketing and with or without MRI, we do not resect tumors more frequently with negative margins using that physical guidance. So simply having a clearer picture is not likely to help. This is probably due to differences in positioning when the patient has mammography, MRI, and operation, and any DCIS at the periphery, which can be harder for MRI to detect. So if you consider all of this additional data, the Houssami results make a lot more sense. And now, we should certainly not be surprised that MRI images, no matter how detailed and beautiful, don't improve patient outcomes. So what about the data in the study? We could be skeptics and debate whether these studies used older MRI machines, had radiologists who were not MRI experts, or performed localizations that might not have been optimal, however you define that. But even if these things are true, the data reflects the widespread reality of the technology and expertise as it recently or currently exists, presenting outcomes as they are rather than as we think they should be. Even modest benefits might have justified MRI's high cost in the non-high-risk routine preoperative setting. But we can't afford to continue using imaging where we can't demonstrate a benefit, despite trying over and over again. We also need to recognize that, at least in the United States, every year breast cancer evaluation and treatment costs go up, and also every year imaging accounts for a greater proportion of those costs. At this point, the routine use of preoperative breast MRI has not been found to have surgical or outcome benefits when used routinely. The Houssami meta-analysis is not a prospective study, but it does add strength to a growing body of data which should tell us that we are unlikely to ever see improvement in outcomes from the use of MRI routinely in the non-high-risk preoperative setting. So how do we move forward? We have to focus on its use for things like Paget's disease, occult primaries, and deleterious BRCA mutation carriers, where it has been demonstrated to be definitively advantageous. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.